Now we move forward in our schedule to welcome our lovely couple and working in our hospital, Dr. Taha and Dr. Miriam. So the session will be shared, and we'll start with Dr. Miriam, who's our pediatric dentist in our hospital with more than 21 years of experience. She has had her degree from School of Dental Medicine in University of Pennsylvania in US. She was awarded the Leo Davidoff Award and served as several teaching positions and worked at different hospitals inside and outside the US. Welcome to the stage, Dr. Mary.
Greetings to everybody. This is kind of a rhetorical question. Don't we all like going to the dentist? And I think we all know the answer to that. If you ever watch The Little Shop of Horrors, you can't miss the dentist scene. And on the remake of Willy Wonka and the Chocolate Factory, the reason why Johnny Depp on the remake was a little bit more creepier than Gene Wilder is because, guess what? As a child, he went to the orthodontist and had orthodontist treatment. How did we get there? Are we just victims? Had the Hollywood industry had just victimized us? I think it's much more than that. We are the ultimate invaders of personal space. They say personal space is a cultural thing. Usually for children in the Western Hemisphere, it's about 45 centimeters. For an adult, double that. Maybe in the Eastern Hemisphere, it's a little bit closer than 45 centimeters. But we are invading this no matter what, even if it's 10 centimeters for you. By necessity, we have to be way too close. Too close for comfort, like they say. When you're reclining in the dental chair, and I had been a patient myself in the dental chair, I don't like it. I feel complete loss of control. Your communication is impaired. I mean, how are you going to tell us how you feel when both hands of us are stuffed in your mouth? Fear of pain and choking. All that water from the drill. I mean, look at the name, it's a drill. Fear of the unknown. What are we going to get next? What's the tool that we're going to get next? Those unpleasant sounds, the light, it might as well be an interrogation room, that headlight, the smells, that eugenol smell. Isn't it very distinctive of a dentist's office? And then past unpleasant experiences that will always tarnish your memory. So where do we go from there? How can we regain the trust? And we are doing it on children, for God's sake. How can we build the rapport? Who are we trying to reach out to? So we thought of, you know what, let's start a little bit earlier. Let's start before the patient hears the horror stories from the mom about going to the dentist. Let's build the dental home. What's the dental home? It's a concept that had been adopted by the American Academy of Pediatric Dentists and the American Dental Association, and we do support that at Al-Musa Hospital. We want to see the child at the age or no later than the age of 1. We want to build what we call the dental home, which is a triangle that encompasses us, the dentists, the families, the caregivers, which are a very important component in our treatment, and the patient themselves. What do we do when the child is less than 1? I mean, do they even have teeth? It's a simple, it's an easy, and it's an effective visit. And in that visit, we go over patient and parent education. Our concern now is to build a rapport with the patient and the families. We want to make sure that we discuss oral hygiene habits with them. Dental caries by the NIH and the CDC had been stated as the most common chronic disease of children. Having cavities is a disease. We sometimes miss that. It's 5 times more common than asthma, 7 times more common than hay fever. We discuss oral habits. What if the child has thumb-sucking habit? Shall we intervene now? Shall we wait until later? We discuss trauma prevention. It's my business if your child is in a car seat or not. Do they wear helmets? I'm in the business of trauma prevention. It's not only tooth fixers. Knowledge is power. When we discuss everything and we have the child come back to us, we discuss the treatment and the treatment plan. And we want to involve the family with that. We want to empower them. We give them options. We give them the pros and cons of each treatment that we suggest to them. We empower the patients and we want to make sure that they make informed decisions. We use illustrations, we use models, we use everything, and we encourage questions. Now that we need to start with the treatment, it's easy to fix a tooth. That's a mechanical thing. It's no big deal. The thing is, how are you going to do it on a child? We have to incorporate the child and their behavior. And by the way, it used to be called behavior management. Then in 2003, after a symposium of the American Academy of Pediatric Dentists, it was changed to behavior guidance. Because you manage a problem, and the child's behavior is not a problem. I mean, sometimes I get asked, how do you do dental treatment on children? I say, how do you do it on adults? The first thing that we do for a child is what we call tell, show, do. We tell the child what we're going to do, and then we show them how we're going to do it, and then we go ahead and we do it. We don't deviate from what we told them. We want their trust. Not only that, we encourage the child or the parent to be in the room, we want the child to be in the room, the parent to be in the room and in the chair with the child. I think we missed the slide here. We had little Latifa held by her mom on the dental chair, and she couldn't be happier. She was only 3 years old. We avoid dental jargon. It's not a drill, it's a whistle brush. It's not local anesthetic, it's the sleepy juice. Then we go over, there are several behavior management or behavior guidance techniques, but there are ones that we use over and over, and almost with every child. One of them is distraction. Abdul Hamid is watching Mr. Bean, the cartoon show, and he did ask for that when he came in before he lied down on the chair. Now we can do our work and he's happy watching his favorite show. Positive reinforcement. Whenever we see a desired behavior, we readily just compliment that. Oh, you did such a good job. I like how you have your hands down. And then children are usually pleasers. They don't want to disappoint you. You said that, they're going to keep on doing it. Modeling. These are all, by the way, pictures from our dental clinic at الموسى, the pediatric dental clinic. Abdul Hamid, when he was on the chair, his brother was having so much fun taping him, and Latifa was watching as well. This is a good model for them. We encourage the siblings to be in the room if we anticipate that the child will display a desired behavior. And if we anticipate that it might not go that well, not because of pain, just because the child does not like reclining, we usually split the parents. I would ask the father or the mother, you know what, how about you guys, somebody stay with me here, and how about you go take Latifa and Abdul Hamid and you go take a walk. They know exactly what I mean. When this device was invented, it was just to isolate the tooth, because most of our dental materials are hydrophobic. They do not go well with saliva. So here is the reason why the rubber dam was invented. But then for a pediatric dentist, it's very rarely that you find a pediatric dentist that does not use the rubber dam. The reason is it eliminates the fear of choking completely. When you, as it says, rubber dam, hold the water away from the back of the throat, the child feels so much better. And you can tell that their behavior just improves by folds and folds when you use the rubber dam. So we use it, or we display it as one of our behavior guidance techniques. This is our new kid in the block. The Buzzy Bee, I got an email. This is the newest addition to our toolbox. I got an email from Dr. Asfa. I don't see if she's here or not. She's our QI director, and she's a dentist herself and the mother of my patient, little Aris. And she got this email from someone else in the hospital. We're like one big family in the hospital. And she said, "Did you see this?" I was like, "What's that?" I have no idea. But let me see, let me research it. This device is just a very simple device. Probably somebody who invented it now are retiring off of it. It creates vibration, and you can hook gel sacks that you can keep in the freezer. And what it does, it distracts the pain while you're giving the injection. Simple device, FDA cleared, and we were just not believing that something like this, something as simple as this, we can have in our clinic. And thank God for Amazon, it's here. I used it yesterday with one of our patients, and we couldn't be happier. When sometimes you need that extra help, when you can't ask the child more than they can give, now we go to pharmacological means. And this is the safest of our pharmacological means, the laughing gas. We love it, our children love it. They love the feeling they have, and look at those thumbs up. Very safe, very limited instances that we don't use or it's contraindicated for, usually not with children. Then when we just have to bypass the child's ability to cooperate, then we move forward to using general anesthesia. This is Ibrahim. Ibrahim came to our clinic. His father heard of us in a family gathering. He took Ibrahim to 4 different hospitals in the last 3 months. Ibrahim had 16 decayed teeth out of his 20. He had everything. He had abscesses, he had pain, he had multiple infections, he was taking antibiotics like water. His father, in that meeting or in that gathering with the family, heard of Al-Musa. He thought, okay, I'll give it a try. He came to us. Ibrahim could not be operated on in the normal setting. He was just too scared. He was too much in pain. It was too many teeth to fix, and we just had to bypass his ability to cooperate. And so we did. To make matters even more complicated, he's a sickle cell disease patient. Every time he gets a pain experience, it puts him at the risk of developing a sickle cell crisis. Every time he has an infection, that puts him at the risk of having crisis as well. So we co-managed him and cooperated with our pediatric hematologist. We had him in the night before. We had him at a strict hydration regimen. We had him at strict pain regimen, and we operated on him. Kept the room warm and nice for him, and we operated. Anything that you can think of, Ibrahim had. He had stainless steel crowns on his molars. He had extractions. He had space maintainers. He had composite crowns. Everything you can think of. This is his pre and post, and his father couldn't be happier. We called him the night after, or the day after. He was doing really well. We saw him a week after, and his father was very thankful. And we told him it's not the end of the story. We want to see you again. We want to keep on pounding those concepts of recalls, because we are not only tooth fixers. We want to make sure that we shift the paradigm. We want to make sure that we are in the business of prevention, not only fixing what's damaged already. We like them better when they're awake and they can communicate with us. Little Fatma was showing off her brushing techniques. She was having our little educational toy, Dino. I'm really not sure if Dino is a dinosaur or an alligator, but it doesn't matter. He looks good, he has teeth. And she was just showing off to Mom what she can do. Now she can brush them well, and she's gonna come back again in 6 months. So we like that more. I practiced in Fairfax, Virginia for quite some time after residency. Practiced in Al-Hassa, and for a short time as a volunteer in Montego Bay, Jamaica. I mean, you can tell maybe some hideous intentions of just seeing the beaches in Jamaica. But it still was volunteer work. And no matter where you go, your patients and their families, they deserve, and that's a note for us too. I'm not only telling you, I'm telling myself. Our patients deserve respect. They deserve to be treated with dignity, and they sure deserve to be treated with compassion. Some stickers and a sense of humor go a long way too. I'll leave you with I'll wrap up with this last story about Al-Hawra. Al-Hawra came to our practice, and her mom was saying she has a tooth that's just bothering her. She would not eat, she would not drink. This tooth is bothering her. Al-Hawra is about 9 years old. I take a look. It's a baby tooth. It's a normal thing for it to exfoliate anytime soon, and she would be okay. But mom said, no, she's not biting, she's not eating at all, she is just complaining all the time. So it would be a good idea if you just take the tooth out for her. I said, okay, easy stuff. This is hanging by a thread, I can do it. And I was like, okay, let me have a comprehensive exam on her. Let me see if she has cavities. She said, okay, go ahead. I do see that she has multiple cavities here and there. I say, how about I numb her on that side? I get the restoration done for her, I get the filling done for her, and then by that time she warmed up to me, then I can take the tooth out for her. Because usually, this is something you're taught back in residency, don't start with the invasive procedure first. It's kind of a behavior guidance technique as well. Don't start with the extractions. So anyway, I numbed her. Thank God, she had no idea that she got the needle. We don't even say the word needle. But I numbed her, lower left side, she's pretty numb. I did the filling for her. And I forgot to say, the moment I sat her on the chair, she said, don't take the tooth out. I said, okay, I'm not gonna take the tooth out. Then when she was done, her mom was like, are you gonna take the tooth out now? She looked at her mom, she looked at me, and she said, don't take the tooth out. Oh, I never thought she would refuse. I thought she would make me, or let me do it. I thought she's gonna be warmed up by now. But she wouldn't. So mom goes behind Al-Hawra, and then she gestures for me, take it out. Okay, what a conundrum now. I will lose her trust if I took it out. But this is the reason why mom got her here. I will lose, mom is not gonna like it. So what do? Then a light bulb lit right here. It's a very, very wiggly tooth. She probably can do it herself. So I said, Al-Hawra, did you have any pain when I did your filling? She said, no, but don't take the tooth out. Now she's fixated on that. I said, no, I'm not gonna take it out. You're gonna take it out. She's like, how? I said, can you touch your tooth now? She's reluctant, she doesn't wanna do it. I said, touch it. Trust me, it doesn't hurt. It's not gonna hurt. So she did, with her index finger, she touched her tooth. And I said, now wiggle it back and forth. Can you do it? She said, I'll try. She started wiggling the tooth, and it was hanging by a thread. The tooth came out. Now we're done. It's a win-win-win situation. I could have done a 2 seconds, what we call fingertip extraction. I could have taken the tooth myself. Thank you. Hawra is the hero here. She took it out herself. She's happy. She knows I did not lie to her. We don't lie to children. We might do it now, but they're never gonna come back again. They will never trust us. We might not say the whole truth, but we don't lie. And so that was my story of trust with her. She got it done, mom is happy, we are happy. Thank you so much for listening. I hope I didn't take much of your time. I'll leave you with this thought. Thank you.